Welcome back to the deep dive. We're here to break down complex clinical topics into, well, into knowledge you can actually use.
That's the goal.
Today, we're diving into something absolutely fundamental, the hematologic system. Think of it as the body's lifeblood, literally.
It really is. And our focus today is pulling directly from your medical surgical nursing text, looking at the core assessments and the big concepts of care for major hematologic issues.
Right, so this is all about synthesizing that textbook information. And the unit really boils down to two critical ideas, doesn't it?
It does. Perfusion and clotting. They're the pillars. Everything in hematology impacts one or both of these. It's all about balance.
Okay, let's define this quickly. Perfusion, that's the blood flow, right?
Yeah.
Getting oxygen everywhere.
Exactly. Total arterial blood flow. You've got central perfusion, the heart pumping it out, and peripheral, getting down to every single capillary. It's non-negotiable for oxygen delivery. Mess with the blood, you mess with perfusion, and the whole body feels it.
And clotting, or hemostasis, the technical term, that's the flip side.
Precisely. It's this incredibly intricate, multi-step dance the body does to stop bleeding. Forms a specific protein clot only where it's needed.
While keeping everything else flowing.
That's the tightrope. Stop the bleeding, but maintain circulation everywhere else. It's a constant balancing act.
So today, we're going to walk through how that works, what happens when it goes wrong, and crucially, what you need to do as a nurse when that balance tips.
All right, first things first. To get the disorders, you have to understand the factory. Where does blood come from?
The bone marrow, that's the production site for all of it. Red cells, white cells, platelets.
And it's not a small operation. Your text mentions it churns out billions of cells per kilogram of body weight every single day.
Wow. And it's not just random production, is it? There's a whole differentiation process. Starts with these unspecialized stem cells.
Blood stem cells, yeah.
Yeah.
They have the potential to become anything, but then they get instructions. They become committed stem cells.
And those need specific signals, growth factors, to decide their final job.
Exactly. So for a red blood cell, an erythrocyte, that committed stem cell needs erythropoietin. That's the signal.
Ah, erythropoietin. That connects to the kidneys, right?
You got it. The mature RBCs, they're these flexible biconcave discs, no nucleus, live about 120 days. Their whole purpose is carrying oxygen via hemoglobin or HGB.
And iron is essential for that HGB molecule. That's the oxygen binding site.
That's the spot. And the kidney is the master regulator. It senses tissue oxygen levels if it detects hypoxia, low oxygen.
It releases more erythropoietin.
Correct, which tells the bone marrow, hey, we need more oxygen carriers, ramp up RBC production. That's erythropoiesis.
Which explains why chronic kidney disease patients almost always have anemia. Their kidneys aren't sending the signal.
It's a direct link. Super important clinical connection. And remember, it's not just the signal. Making good HGB and RBCs needs the raw materials too.
Right, you need iron, obviously, but also things like vitamin B12, folic acid, copper, I think.
Yeah, copper, pyridoxine, cobalt, a whole list.
Yeah.
If you're deficient in any of those key ingredients, the quality or quantity of your RBCs suffers.
And that leads to a specific type of anemia?
Which in turn impacts perfusion across the whole body. See how it all connects.
Definitely. Okay, what about the liquid part? Plasma.
Plasma is mostly water, but it carries crucial proteins. Three big ones to know. Albumin keeps fluid in the vessels, maintains osmotic pressure.
Like a sponge, almost.
Sort of, yeah. Then globulins, they transport stuff and are vital for immunity. And fibrinogen, remember that one?
Fibrinogen sounds like fiber. Clotting.
Exactly. It's the inactive precursor protein that becomes fibrin, the actual mesh of a stable blood clot.
Okay, perfect segue. Let's talk clotting cascade, hemostasis. You said it's 3 steps.
Yeah, a sequence. First, platelet aggregation. Platelets rush to the injury site, get sticky, and form a temporary plug. Things like calcium and exposed collagen help them activate.
So step 1 is the temporary patch.
Right. Step 2 is the big one, the blood clotting cascade. The book calls it a landslide, which is a great analogy.
A landslide? How so?
Because it's an amplification process. One inactive clotting factor gets activated, it activates more than the next factor, and so on. It ramps up incredibly fast, creating a huge response from a small initial trigger.
Okay, massive amplification. Then step 3.
Fibrin clot formation. An enzyme called thrombin activates that fibrinogen we mentioned
Into fibrin.
And that fibrin forms a strong, durable mesh that reinforces the platelet plug, making a stable clot.
The text mentions 2 main pathways that trigger this cascade, extrinsic and intrinsic.
Yeah, and the difference matters clinically. The extrinsic pathway is the fast one. Think external trauma, a cut, a major injury. It exposes tissue factors outside the vessel. It's designed for rapid response to stop bleeding quickly.
Hmm.
Protective.
Okay. And intrinsic.
That's slower. Triggered by conditions inside the blood vessel. Things like abnormal blood flow, venous diastasis like sluggish blood in leg veins, or inflammation on the vessel wall.
So this is the pathway more involved in clots we don't want, like DVTs or arterial clots.
Often, yes. It's triggered by internal changes rather than external injury.
And both pathways use these clotting factors, the Roman numeral guys.
Yep. They're mostly inactive enzymes waiting for the signal. And calcium factor 4 is needed almost everywhere in the cascade. It's a critical cofactor.
And vitamin K, that's huge, right, for specific factors.
Absolutely crucial. The liver needs vitamin K to produce factors 2, CAIX, and X. Can't make them without it.
So if someone has liver disease, like from alcoholism, or isn't absorbing vitamin K properly,
Their clotting is impaired. That's why your assessment has to include liver history, alcohol use, diet, any GI issues affecting absorption. It directly ties back to this biochemistry.
okay, but if this cascade is like a landslide, why doesn't every tiny paper cut cause a massive clot that blocks everything?
The balance. That's where the anti-clotting forces come in. As the clot forms, the body simultaneously activates inhibitors, things like protein C, protein S, antithrombin III.
They're like the brakes.
Exactly. They patrol the area, keeping the clot localized just to the injury site, preventing it from spreading uncontrollably.
And if someone is deficient in those proteins,
Big trouble. Their risk of unwanted clots, VTE, PE, MI stroke goes way up. That balance is lost.
and then there's cleanup, fibrinolysis.
Right. Once the vessel is healed, you need to break down the clot. That's fibrinolysis. An enzyme called plasmin, activated from plasminogen, slowly dissolves the fibrin mesh around the edges. Keeps the vessel clear long term.
It's an incredibly elegant system when it works.
When it works, yeah.
Yeah.
But let's consider how aging affects it. The system isn't immune to time.
Right. Older adults.
What?
What changes do we typically see?
Well, blood volume tends to decrease slightly. Plasma proteins might be lower, maybe due to diet or just slightly less efficient liver function.
Okay.
And importantly, the active red bone marrow, the factory, gets gradually replaced by fatty tissue.
So less production capacity.
Generally, yeah. Leads to slightly lower baseline RBC and WBC counts. Platelets usually stay stable, though, and HGB levels tend to drift down a bit after middle age.
What's the big clinical takeaway from those aging changes?
The WBC response. It's often slower and less robust in older adults.
Right.
So a serious infection might not trigger that high fever or dramatic white count you'd expect.
You could be really sick but not look it on the labs initially.
Precisely. You need a high index of suspicion. Subtle changes might be your only clue.
Okay, let's get into the hands-on assessment. History first. What are the priority cues?
We've hit some already. Liver function, jaundice history, gallstones, alcohol use. Previous radiation therapy can damage marrow. Drug history is huge, especially NSAIDs, aspirin, anticoagulants.
The blood thinners, even though they don't really thin the blood.
Right, they interfere with clotting factors or platelets. Need to ask about those specifically.
Right.
Diet is critical. Vitamin K intake, sure, but also protein and iron. Is the patient getting enough? Can they afford it?
Yeah.
Chronic alcoholism depletes folate and affects the liver.
And genetic.
Absolutely. Family history of bleeding disorders like hemophilia, clotting disorders, sickle cell disease. Need to ask.
What about current symptoms? What should raise a red flag?
Fatigue. Overwhelming fatigue is the most common symptom of anemia. It's not just being tired, it's profound exhaustion because the cells aren't getting enough oxygen to make energy ATP.
Okay, fatigue is number one. What else?
Vertigo, dizziness, tinnitus, ringing in the ears. A sore tongue can be a clue, and obviously any excessive bruising or bleeding, nosebleeds, heavy periods.
The text mentions using coins or fruit to quantify menstrual bleeding.
Yeah, it sounds a bit odd, but asking, are the clots bigger than a quarter?
Yeah.
Gives you a much more objective measure than just, is it heavy? It helps track changes over time, too.
Good tip. Now, the physical exam. You mentioned safety priorities earlier.
Two big ones. First, handle gently, always, especially if you suspect low platelets, thrombocytopenia. You don't want to be the cause of bruises or bleeding.
And the second?
This is critical. If you suspect the spleen might be enlarged, maybe from infection, or certain blood disorders, do not palpate the splenic area.
Why not?
Risk of rupture. An enlarged spleen is fragile. Pushing on it could cause it to rupture, leading to massive internal hemorrhage. It's a life-threatening emergency. Just don't do it.
Got it. Avoid the spleen if enlarged. What are we looking for on exam? Skin.
Pallor, obviously. Check mucous membranes, gums, conjunctivae, especially in darker-skinned individuals where skin pallor is harder to see. Look at palmar creases, too. jaundice, yellowing, check the roof of the mouth, or sclera.
And bleeding signs.
Petechia, those tiny pinpoint reddish-purple dots, and ecchymosis bruises. Note their size, location, pattern.
The text mentions hair patterns.
Yeah, it's a subtle clue for perfusion. Sparse or absent hair on the lower legs and toes often indicates poor, chronic arterial blood flow. Maybe not directly a blood disorder symptom, but it points to circulatory compromise that could be worsened by anemia, for example.
Interesting. Mouth assessment.
Check the tongue. A smooth, shiny tongue can point to pernicious anemia or iron deficiency. A classic, beefy red smooth tongue often signals B12 deficiency, that's glossitis. Also, check lymph nodes in the neck and elsewhere. Size, tenderness, are they fixed or mobile?
And systemically, what tells us perfusion is poor overall?
Tachycardia, heart beating faster to compensate. Maybe lower systolic blood pressure if anemia is significant. Conversely, high BP could suggest thick blood, like in polycythemia vera. Check pulses. Are they weak, thready? Is the patient short of breath with minimal exertion? That's dyspnea on exertion. Even check urine for blood or protein.
Lots of places to look. Let's move to diagnostics. Labs. CBC is baseline.
Yep, complete blood count gives you the raw numbers. RBC count, WBC count, hemoglobin, hematocrit. But the RBC indices are key for figuring out why someone's anemic.
How so?
They tell you about the cells themselves. MCV, mean corpuscular volume, tells you the average size. Are they microcytic, small, like in iron deficiency, or macrocytic, large, like in B12 or folate deficiency?
And MCH-MCHC,
mean corpuscular hemoglobin and concentration, tells you about the hemoglobin content. Are the cells hypochromic, pale, because they don't have enough HTB? This helps classify the anemia, which guides the treatment.
Okay, shifting gears to clotting tests. PTINR.
Trothrombin time, standardized by the International Normalized Ratio, measures the extrinsic pathway, absolutely essential for monitoring warfarin therapy. That target INR, usually 2.0 to 3.0, is something you'll manage constantly.
And PTT.
Partial thromboplastin time, assesses the intrinsic cascade. A prolonged PTT might indicate a factor deficiency, like in hemophilia, or the effect of heparin.
Speaking of heparin, the anti-factor Z test.
Yes, that's become the more precise way to monitor heparin levels compared to just the PTT for therapeutic anticoagulation. And don't forget the platelet count. Normal is roughly 150,000 to 400,000.
A danger zone.
Risk of spontaneous bleeding really climbs below 50,000, and it's critical, potentially fatal, below 20,000.
Wow. Okay, iron studies. Ferritin, transferrin, TIBC. These can be confusing.
They can. Serum ferritin reflects your total body iron stores. Transferrin is the protein that transports iron in the blood.
And TIBC, total iron binding capacity.
TIBC measures how many seats are available on those transferrin transport proteins. Here's the tricky part. When serum iron is low, iron deficiency, the TIBC usually goes up.
That seems backward.
Think of it like this. Transferrin molecules are buses designed to carry iron passengers. If you're iron deficient, you have very few iron passengers, low serum iron. So most of the buses transferrin are empty. The TIBC measures the total capacity of all buses, empty or full. So lots of empty buses means a high TIBC. It signifies the body needs iron.
Okay. High capacity because it's not being used. That makes sense. Last assessment piece, bone marrow aspiration and biopsy.
This is the definitive test to see what the factory is actually doing. How are cells being produced? Are they maturing correctly? Are there abnormal cells, like blasts and leukemia?
Sounds invasive and probably scary for the patient.
It is. Patient prep is key. Explain the procedure clearly. They'll feel heavy pressure, a pushing sensation. The aspiration part involves a brief, sharp, pulling pain. Acknowledge the anxiety, provide support.
And nursing priorities during and after? Safety first.
Absolutely. Two big ones. First, during the procedure, sterile technique is mandatory. High risk of introducing infection directly into the bone.
Okay. And after?
Second priority, prevent excessive bleeding. This is huge. Apply firm pressure to the site, often using a pressure dressing or even a sandbag for a period. Monitor the site closely. The text says every 2 hours. For the first 24 hours, check for bleeding, swelling, hematoma.
And activity restrictions, pain meds.
Advise the patient to avoid any trauma to the site for about 48 hours. For pain, use only aspirin-free analgesics like acetaminophen. Aspirin would increase bleeding risk.
All right, let's apply these concepts. We'll use sickle cell disease, SCD, as our main example for perfusion problems.
Perfect example. It shows how one tiny genetic change can wreak havoc on the entire circulatory system.
So the core issue is the hemoglobin itself, right?
Exactly. A genetic mutation causes the body to make hemoglobin S, HbS, instead of the normal adult hemoglobin A,
Yeah.
HbA. And HbS is, well, fragile and sensitive.
Sensitive to low oxygen.
Very sensitive. When oxygen levels drop, HbS causes the normally flexible, round red blood cell to deform into a rigid C-shaped sickle.
And those sickled cells cause
Big
problems.
problems. Two main ways. First, they're stiff and sticky. They clump together easily and block small blood vessels. This blockage is called a vaso-occlusive event, or VOE,
The blockage cuts off blood flow.
causing tissue hypoxia downstream. And here's the terrible feedback loop. That hypoxia causes more nearby cells to sickle.
Oh, wow. So it just gets worse and worse?
It spirals. More sickling, more blockage, more pain, more tissue damage.
Okay.
This is the classic sickle cell crisis, or vaso-occlusive crisis, VOC. Leads to ischemia and that characteristic intense pain.
Okay, that's one problem, the blockage. What's the second?
The lifespan of the cells. Normal RBCs live about 120 days. Sickled cells are fragile and get destroyed much faster, maybe only 10 to 20 days,
So constant destruction of red cells.
leading to chronic hemolytic anemia. The body just can't keep up with replacing them that quickly.
What triggers a crisis? What makes the cells sickle?
Anything that lowers oxygen levels or stresses the body. Hypoxia is the big one, obviously. But also, dehydration makes the blood thicker, stickier. Infection increases metabolic demand. High altitudes, unpressurized airplanes, strenuous exercise, conditions like acidosis, even temperature extremes, especially cold, can trigger vasoconstriction and sickling. Nicotine use is a big no-no too.
So patient education on avoiding these triggers is huge for prevention.
Absolutely critical for self-management.
What are the main clinical signs we see, besides the anemia?
Pain. Pain is the hallmark symptom. It's usually acute, severe, often described as gnawing or throbbing. Can be anywhere, but common in the chest, back, abdomen, joints, extremities, leads to frequent ER visits and hospitalizations.
What about long-term effects? Cardiovascular.
Yeah, the chronic anemia puts a huge strain on the heart. It has to pump faster and harder to try and deliver enough oxygen. This can lead to high-output heart failure over time.
So you'd assess for tachycardia, maybe murmurs, an S3 sound, check peripheral perfusion.
Definitely. Cool extremities, slow capillary refill, weak pulses, all signs the heart is struggling or there's peripheral occlusion. Low baseline BP is common due to the anemia, but it can fluctuate.
And the most dangerous complication, acute chest syndrome.
ACS, yes. Life-threatening, and the most common cause of death in SCD patients. It's basically sickling of the pulmonary vessels.
Presence like pneumonia.
Exactly. Cough, shortness of breath, chest pain, fever, infiltrate on the chest x-ray. But the cause is vaso-occlusion in the lungs. It requires immediate aggressive treatment, oxygen, fluids, often exchange transfusions, can progress rapidly to respiratory failure.
Scary. What other manifestations are common?
Priapism, a prolonged painful erection in males due to blood trapping in the penis. It's an emergency, can cause permanent damage. Jaundice is common from all the bilirubin released by destroyed RBCs. Chronic leg ulcers, especially around the ankles, due to poor perfusion. Kidney damage is frequent over time, leading to chronic kidney disease.
And the brain, all that hypoxia.
Can cause strokes, even silent ones that accumulate damage. Seizures can occur. Watch for any subtle cognitive or behavioral changes. Confusion, irritability, they might be early signs of cerebral hypoxia.
Okay, patient comes in with a crisis. What's the absolute top priority?
Pain management, period. This pain is real, it's severe, and it needs aggressive treatment.
How aggressive.
Start with scheduled 5E opioid analgesics, usually for at least the first 48 hours. Morphine, hydromorphone, Dilaudid are common, often via PCA pump, patient-controlled analgesia.
Scheduled, not PRN?
Absolute not PRN during the acute phase. Waiting until the pain is unbearable and then asking for meds just doesn't work. It leads to suffering and reinforces anxiety. Consistent dosing breaks the pain cycle.
And we need to address the stigma.
We really do. These patients live with chronic, severe pain. Addiction rates are actually quite low in this population when opioids are used appropriately for pain. Undertreating their pain due to unfounded fears is unethical and harmful, believes the patient's report of pain.
Okay, pain meds on board. What are the other key nursing actions during a crisis? Best practices.
Oxygen first, even if SATs look okay. Supplemental O2 can help reduce further sickling. Hydration is critical. Push IV fluids, often hypotonic solutions like D5W or half-normal saline, starting at a high rate, maybe 250 milliliter initially, to dilute the blood and improve flow.
What else? Positioning, environment.
Remove any constrictive clothing. Keep extremities extended, avoid bending knees sharply on the bed, promotes venous return. Keep the room warm temperature above 72 degrees Fahrenheit, helps prevent vasoconstriction from cold. Minimize stress. cluster care.
What about long-term drug therapy to prevent crises?
Hydroxyurea is a key player. It actually stimulates the bone marrow to produce more fetal hemoglobin, HbF.
And HbF doesn't sickle.
Right. So more HbF means less HbS, less sickling. Overall, it reduces crisis frequency and severity.
Important safety points with hydroxyurea.
Two big ones. It suppresses bone marrow function, so increased risk of infection. Monitor blood counts closely. And it's a teratogen, causes birth defects. So strict contraception is absolutely required for women of childbearing age taking it, and during treatment for men as well.
Are there newer drugs?
Yes, things are evolving. Endari, which is L-glutamine, seems to reduce oxidative stress on the cells, making them last longer. And crisanlizumab is a monoclonal antibody.
How does that work?
It targets adhesion molecules on the surface of endothelial cells and platelets. Basically, it makes the blood vessel walls in the cells less sticky, preventing them from clumping up and causing a VOE. It's given IV monthly.
Very targeted. What about infection risk overall? You mentioned the spleen earlier.
Huge issue. Repeated sickling often damages the spleen so badly it becomes non-functional, functional asplenia. The spleen is critical for filtering bacteria.
So they're essentially immunocompromised.
In a way, yes. Highly susceptible to certain bacterial infections, especially encapsulated organisms like pneumococcus. That's why prophylactic antibiotics, often daily penicillin, especially in children, are standard. And vaccinations, pneumococcal, meningococcal, influenza, are vital.
And any sign of infection
Is a potential emergency. Strict aseptic technique for any procedure. And here's a critical rescue point from the text. A temperature elevation of even 1 degree Fahrenheit, or 0.5 Celsius, above their baseline needs immediate attention. Assume sepsis until proven otherwise. Get cultures. Start broad-spectrum IV antibiotic stat. Don't wait.
Okay. Self-management education is clearly vital. What are the key takeaways for patients?
Drain fluids aim for 3 to 4 liters daily unless contraindicated. Avoid alcohol and smoking nicotine completely. Get prompt treatment for any illness, even a cold. Avoid temperature extremes. Dress warmly in cold. Stay cool in heat. Avoid high altitudes and unpressurized aircraft. Exercise is good, but avoid overly strenuous activities that could cause hypoxia or dehydration. Low impact is better.
Any specific gender health notes? Pregnancy.
Pregnancy is very high risk, potentially life-threatening for both mother and baby due to increased metabolic demands and clotting risk. Requires specialized care. For contraception, progestin-only methods are generally preferred. Combined hormonal contraceptives, estrogen plus progestin, can increase clotting risk, especially if the woman also smokes.
Okay, SCD is a major perfusion issue, but anemia itself is it's a sign, right? Not one single disease.
Exactly. Anemia just means low RBCs, low HGB, or low HDT. It's a clinical indicator that something is wrong. And while the causes vary wildly, the symptoms are often similar because they all relate back to decreased oxygen delivery.
Pallor, cool skin, fatigue, tachycardia, maybe feeling dizzy when standing up. Orthostatic hypotension.
Those are the classics. Let's touch on a few specific types you'll definitely encounter. Iron deficiency anemia.
The most common one worldwide.
Yep. The red cells are typically small, microcytic, and pale hypochromic. The cause is usually either blood loss, and you must investigate potential GI bleeding or inadequate intake absorption.
Management seems straightforward. Increase iron.
Usually. Oral iron supplements are the first line. Ferrous sulfate is common. Need to teach patients how to take it for best absorption, like with vitamin C, not with milk or antacids, and warn about side effects like constipation and dark stools. Increase dietary iron: red meat, poultry, fish, leafy greens, beans, fortified cereals.
What if oral iron doesn't work or isn't tolerated?
Severe cases, or those with absorption issues like after gastric surgery, might need parenteral iron IV infusions. Fermoxytol is one, but it comes with a significant risk.
The black box warning.
Yes, for potentially fatal anaphylaxis. Needs careful administration and monitoring.
Okay, next big one. Vitamin B12 deficiency. This one makes the cells different, right?
Right. This is a megaloblastic or macrocytic anemia. The RBCs are large and immature because B12 is needed for DNA synthesis during cell division.
What usually causes it?
Most often, it's a failure to absorb B12 from the gut. The classic cause is pernicious anemia.
That's autoimmune.
Yes. The body makes antibodies against intrinsic factor, a substance made in the stomach that's necessary to absorb B12. No intrinsic factor, no B12 absorption, no matter how much they eat.
What are the key signs of B12 deficiency, besides the general anemia symptoms?
Pallor, maybe slight jaundice. The tongue glossitis, that smooth, beefy red appearance, is characteristic. But the big differentiator is the neurologic involvement.
Nerves need B12 too.
Critically, Deficiency causes paresthesias, numbness, tingling in hands and feet, poor balance, memory problems, confusion. These can become permanent if not treated promptly.
So treatment isn't just eating more B12.
Not if the cause is pernicious anemia, lack of intrinsic factor. Oral B12 won't be absorbed. Treatment is lifelong B12 injections, usually monthly, bypassing the gut entirely.
Got it. Okay, aplastic anemia sounds really serious.
It is. It's not just RBCs. It's pancytopenia, a deficiency of all blood cell types, red cells, white cells, and platelets.
What causes the bone marrow to just fail like that?
It's often idiopathic, unknown cause, but it can be triggered by exposure to certain toxins, drugs, radiation, or sometimes viral infections. Essentially, the bone marrow stem cells are damaged or destroyed.
How do you treat it?
It's tough. Hematopoietic stem cell transplant, HSCT, or bone marrow transplant offers the best chance for cure, especially in younger patients. Immunosuppressive therapy, using drugs like cyclosporine and antithymocyte globulin, is another option to stop the immune system from attacking the marrow, if that's the cause. Sometimes splenectomy is done if the spleen is suspected of destroying cells too quickly, but supportive care transfusions, infection prevention is crucial.
Briefly, G6PD deficiency. Genetic.
Yes, X-linked recessive, so more common and severe in males. It's an enzyme deficiency that makes RBCs fragile. They break down hemolysis when exposed to certain triggers.
Like what?
Common ones are aspirin, sulfa drugs, antimalarials, fovabines, certain infections.
So management is mostly avoidance.
Primarily. Screen high-risk populations. Educate patients to avoid their known triggers. If hemolysis does occur, the big risk is kidney damage from all the cell debris. So aggressive hydration, sometimes osmotic diuretics, are needed to flush the kidneys and prevent acute kidney injury, AKI.
Okay, let's flip the script entirely. Instead of too few cells, what about too many? Polycythemia vera, PV.
Right. PV is a type of blood cancer, specifically a myeloproliferative neoplasm, MPN. The bone marrow goes into overdrive, excessively producing RBCs mainly, but often WBCs and platelets too.
So the blood gets...
Thick, extremely thick, hyperviscous. Think sludge instead of free-flowing liquid. Over 90% of PV patients have a specific mutation in the JAK2 gene that drives this overproduction.
What does that hyperviscosity do to the patient?
Causes a lot of problems. They often have this characteristic dark, flushed, almost purple look to their face called plethora. Intense itching, pruritus, is common, likely due to histamine release from increased mast cells. Hypertension is almost universal because the heart is struggling to pump that thick blood.
And paradoxically, they can be hypoxic, even with tons of RBCs.
Yes. Because the blood flow is so sluggish in the capillaries, oxygen exchange is poor. Despite the high RBC count, tissues aren't getting enough oxygen. They can also have bizarre clotting and bleeding problems because the platelets might be numerous but dysfunctional.
And the high cell turnover causes other issues.
Like gout, rapid cell breakdown releases purines, which get metabolized into uric acid, leading to hyperuricemia and gout symptoms.
How do you manage PV? It's a cancer, you said.
It is. Treatment aims to reduce the cell count and blood viscosity to prevent clots. The main therapy is therapeutic phlebotomy, literally removing blood.
Like bloodletting.
Essentially, yes. Patients might need it frequently, like 2 to 5 times a week initially, then periodically to keep their hematocrit below a target level, usually 45%. Aggressive hydration helps thin the blood. Promoting venous return, avoiding tight clothes, elevating feet is important.
What about medications?
Low-dose aspirin is often used to reduce clotting risk, but you have to balance that against potential GI bleeding. For patients needing more aggressive cytoreduction, chemotherapy agents like hydroxyurea are used to suppress bone marrow production. Newer targeted drugs like JAK inhibitors, AG ruxolitinib, are also used.
Okay, moving into the, frankly, malignant disorders. Leukemia and myelodysplastic syndromes, MDS. What's the core problem here?
Uncontrolled production of immature white blood cells called blast cells in the bone marrow. These blasts are cancerous and don't function properly.
And they crowd out the normal cells.
Exactly. They take over the bone marrow, suppressing the production of normal RBCs, causing anemia, normal platelets, causing thrombocytopenia and bleeding risk, and normal mature WBCs, causing leukopenia and infection risk.
So even though the WBC count might be sky high, it's all useless blasts.
Precisely. They offer no protection against infection. The patient is severely immunocompromised.
What causes leukemia? Risk factors.
Often, the exact cause is unknown. But known risk factors include exposure to ionizing radiation, previous chemotherapy for other cancers, certain chemical exposures like benzene, some viral infections, and certain genetic conditions like Down syndrome. MDS is often considered a pre-leukemic condition.
How is it diagnosed definitively?
Bone marrow aspiration and biopsy is the gold standard. It will show the marrow packed with these immature blast cells.
And chromosome analysis, that sounds important for treatment.
Very important. Cytogenetic studies look for specific chromosomal abnormalities. The classic example is the Philadelphia chromosome.
What's that?
It's a specific translocation bits of chromosome 9 and 22 swap places. It's found in most cases of chronic myelogenous leukemia, CML, and some types of acute lymphoblastic leukemia, ALL. Finding it not only confirms the diagnosis, but also opens the door for targeted therapies like tyrosine kinase inhibitors, TKIs, which have revolutionized CML treatment.
So manifestations reflect the lack of normal cells, anemia, infection, bleeding.
Yes. Fatigue is profound, partly from anemia, partly from the cancer cell's high metabolic rate. Easy bruising, nosebleeds, petechiae from low platelets, fevers, frequent infections that don't clear easily due to lack of functional WBCs. Sometimes neurological symptoms of leukemia cells infiltrate the CNS: headache, vomiting, papilledema, swelling of the optic discs.
Leukemia treatment is intense, the 3 phases.
Right. Induction, consolidation, and maintenance. Induction is the first phase, high-dose, intensive chemotherapy aimed at achieving a rapid remission, killing off as many leukemia cells as possible.
But this chemo wipes out everything, right?
Everything. It causes severe bone marrow suppression, leading to profound neutropenia, dangerously low levels of neutrophils, the main infection-fighting WBCs. The absolute neutrophil count, ANC, can drop below 100, even close to 0.
This sounds like the most dangerous period.
It absolutely is.
Yeah.
This is when the patient is at the highest risk for life-threatening infections and bleeding. They often require prolonged hospitalization, maybe 2-3 weeks or more, just waiting for their counts to recover, the nadir period being the lowest point.
Okay, that's induction, then consolidation.
Once remission is achieved, blasts are cleared from the marrow, consolidation therapy begins. It's another course of chemotherapy, sometimes different drugs or doses, given early in remission. The goal here is cure to eliminate any remaining leukemia cells that might be hiding.
And maintenance.
This is lower dose therapy, often oral chemo, given for months or even years, primarily for certain types of leukemia like AL, to maintain the remission and prevent relapse.
Throughout all this, especially induction, infection prevention is paramount.
Non-negotiable. Meticulous hand washing by everyone. Strict aseptic technique for all procedures, IVs, central lines, etc. Monitoring the CBC and ANC daily is crucial. Protective isolation, neutropenic precautions might be needed.
And that temperature alert again.
Critical rescue. A fever in a neutropenic patient is a medical emergency. Even a slight elevation, 1 degree R or 0.5 degrees C above baseline, needs immediate action. Cultures, blood, urine, sputum, site-specific, must be drawn before starting antibiotics, but don't delay antibiotics waiting for results. Start broad-spectrum IV antibiotics immediately as per protocol. Time is critical.
What about hematopoietic stem cell transplantation, HSCT? Bone marrow transplant, when is that used?
It's often the standard treatment, especially for acute leukemias once they're in remission, offering the best chance for a long-term cure. Also used for aplastic anemia, lymphomas, myeloma, and other disorders.
It sounds like a reset for the bone marrow.
It is, but it's incredibly demanding.
Yeah.
First, the patient undergoes the conditioning regimen.
What's that involve?
High-dose chemotherapy, sometimes with total body irradiation, TBI. The goal is myeloablation, completely destroying the patient's existing bone marrow, including any residual cancer cells. This conditioning is lethal on its own. The patient must receive the transplant afterward to survive.
Wow. Then the transplant itself, day T0.
Transplantation day is actually anticlimactic in a way. The donor stem cells, which could be from bone marrow harvest, peripheral blood stem cell collection after mobilization, or umbilical cord blood, are infused through a central line, much like a regular blood transfusion.
Any special precautions for the infusion?
Yes. Action alert. Do not use standard blood transfusion tubing with a filter. The stem cells can get trapped in the filter. Use specific tubing without a filter or one designed for stem cells.
Then you wait for engraftment.
Yes. Engraftment is when the donor stem cells find their way to the marrow space, start multiplying, and begin producing new blood cells. It typically takes 14 to 21 days. Seeing the WBC, RBC, and platelet counts start to rise is the sign it's working. Until then, the patient is profoundly pancytopenic and at high risk.
What are the major complications after HSCT?
2 big immunological ones are key. First, graft versus host disease, GVHD.
The donor cells attack the patient.
Exactly. The donor T lymphocytes recognize the patient's tissues, often skin, GI tract, liver, as foreign and mount an immune attack. It can range from mild rashes to severe, life-threatening multi-organ damage. It's managed with immunosuppressive drugs like cyclosporine or tacrolimus. Interestingly, a little bit of mild GVHD can be associated with a lower relapse rate, graft versus leukemia effect, but severe GVHD is dangerous.
Okay, GVHD. What's the other one?
Sinusoidal obstructive syndrome, SOS, formerly called veno-occlusive disease, VOD. This is damage to the small blood vessels, the sinusoids, within the liver caused by the high-dose conditioning chemo.
What does that look like?
Blockage and inflammation lead to liver congestion. Symptoms are jaundice, tender and large liver, actinomegaly, right upper quadrant pain, ascites, fluid in the abdomen, and rapid weight gain due to fluid retention. Requires careful fluid management and supportive care. Can be severe.
And throughout that engraftment period, bleeding risk is still high.
Extremely high. Platelet recovery is often the slowest. The nadir, the lowest point of blood counts after conditioning, lasts for weeks. Any platelet count below 50,000 millimeters carries significant bleeding risk.
And below 20,000.
Spontaneous, potentially fatal bleeding, like intracranial hemorrhage, can occur even without injury. Nursing care must focus intensely on minimizing injury. Bleeding precautions are essential. A set for any signs of bleeding petechiae, bruising, oozing from lines, blood in urine or stool every 4 hours is recommended.
Any other subtle signs of internal bleeding?
Measuring abdominal girth daily can be an early indicator of slow internal hemorrhage if the girth is increasing.
Okay, let's shift from leukemia, which starts in the marrow with immature cells, to lymphomas. These are different.
Yes, lymphomas are cancers of committed lymphocytes. Cells are T cells, that typically arise in the lymphoid tissues, lymph nodes, spleen, etc., forming solid tumors, rather than circulating freely like leukemia blasts initially.
Two main types, Hodgkin and non-Hodgkin.
Right. Hodgkin lymphoma, HL, has some distinct features. It often peaks in two age groups, teen young adults and then again in older adults, 50s, 60s. The hallmark diagnostic feature is the presence of Reed-Sternberg cells in the lymph node biopsy.
And it spreads differently.
Tends to spread in a more orderly, predictable pattern from one lymph node group to the next. This predictability helps with staging and treatment planning. HL is generally considered highly curable, especially when caught early.
Any long-term concerns for survivors?
Yes, unfortunately. Due to the treatments used, radiation, certain chemos, long-term survivors have an increased risk of developing secondary cancers, like breast or lung cancer, leukemia, and cardiovascular disease years down the road. Requires lifelong monitoring.
Okay, then non-Hodgkin lymphoma, NHL.
NHL is actually a much broader category, encompassing over 60 different subtypes. They vary widely in aggressiveness and behavior. NHL generally spreads less predictably than HL.
Risk factors for NHL.
Can include things like immunosuppression, post-transplant patients, HIV infection, exposure to certain pesticides and chemicals, viral infections like Epstein-Barr virus. Treatment depends heavily on the specific subtype and stage, ranging from watchful waiting for slow-growing types to intensive chemo, radiation, monoclonal antibodies like rituximab, and newer therapies.
Like CAR-R T-cell therapy that was mentioned?
Well, yes, chimeric antigen receptor T-cell therapy. It's a game changer, especially for relapsed or refractory B-cell lymphomas and some leukemias.
How does it work again? Briefly.
You harvest the patient's own T-cells, genetically engineer them in a lab to express a special receptor, the CIR, that specifically targets a protein on the surface of the cancer cells, like CD19 on B cells. Grow millions of these engineered T cells, then infuse them back into the patient.
So the patient's own immune cells become targeted cancer killers.
Exactly. Personalized immunotherapy. It can lead to dramatic remissions in patients who had run out of other options.
But there's a unique side effect, cytokine release syndrome.
CRS. Yes. It's a major potential complication. When those CAR T cells activate and start killing cancer cells, they release a massive flood of inflammatory signaling molecules called cytokines.
What does that look like clinically?
Can range from mild flu-like symptoms, fever, chills, aches, to severe, life-threatening systemic inflammation with high fevers, dangerously low blood pressure, hypotension, hypoxia, organ dysfunction. Requires vigilant monitoring and prompt management, often with drugs that block specific cytokines, like tocilizumab. Neurotoxicity can also occur.
High risk, high reward therapy. Let's move to multiple myeloma, MM, another blood cancer.
Yes, but different again. MM is a cancer of mature B lymphocytes, specifically the plasma cells, which normally produce antibodies. In MM, these malignant plasma cells proliferate in bone marrow.
And they produce abnormal antibodies.
They produce excessive amounts of a single non-functional antibody called a paraprotein, or M protein. This is the gammopathy. This excess protein causes several problems.
Like thickening the blood.
Yes, it increases blood viscosity. It can also clog the filtering tubules in the kidneys, leading to kidney damage or failure myeloma kidney.
And it affects the bones.
Critically, the myeloma cells secrete factors that stimulate osteoclasts, cells that break down bone, and inhibit osteoblasts, cells that build bone. This leads to widespread bone destruction.
So patients get bone pain, fractures.
Severe bone pain is often the presenting symptom. Pathological fractures, breaking a bone with minimal or no trauma, are common. X-rays often show characteristic helictic lesions, punched out holes in the bone, sometimes described as a Swiss cheese appearance. This bone destruction also releases calcium into the blood, causing hypercalcemia.
And it affects normal blood cell production too.
Yes, the malignant plasma cells crowd out the normal marrow elements, leading to anemia, increased infection risk because normal antibody production is suppressed, and sometimes thrombocytopenia. Easy bruising is common.
What's the main management priority for...
Pain control is huge, given the bone involvement. Preventing fractures is key. Treatment has evolved significantly. It often involves combinations of drugs, including proteasome inhibitors, like bortezomib, immunomodulating drugs, like lenalidomide or thalidomide, steroids, and sometimes chemotherapy. Bisphosphonates, like zoledronic acid, are given to slow down bone destruction and treat hypercalcemia. Stem cell transplant may be used in eligible patients.
Is it curable?
Generally considered incurable, but treatable. With modern therapies, survival has improved dramatically, often exceeding 10 years now, managed as a chronic disease.
Okay, last category in this section, thrombocytopenic purpura. These are about platelet destruction, right? Not production failure like aplastic anemia.
Correct. The marrow makes platelets okay, but they're being destroyed too quickly in the circulation.
Autoimmune TPP, ATP,
Yeah.
also called ITP.
Yes, immune thrombocytopenic purpura. The immune system mistakenly makes antibodies against the patient's own platelets, marking them for destruction, usually in the spleen, often seen in younger women. Can sometimes be triggered by viral infections.
How is it treated?
Initial treatment often involves corticosteroids, like prednisone, to suppress the immune system. Immunoglobulin, IVIG, can provide a temporary boost in platelet count. For refractory cases, drugs that stimulate platelet production, TPO receptor agonists or splenectomy might be considered. Rituximab is also used.
Then there's thrombotic TPP, TTP. This sounds more complex.
It is. TTP is a rare, serious autoimmune disorder. It involves the formation of abnormal platelet clumps or microthrombi in small blood vessels throughout the body.
So clots form where they shouldn't.
Exactly. These microclots obstruct blood flow, causing damage to organs like the kidneys, brain, leading to stroke-like symptoms, confusion, seizures, and heart, NAI. And because platelets are being consumed in these abnormal clots.
The patient doesn't have enough left to stop bleeding when they actually need to.
That's the dangerous paradox. They have inappropriate clotting and a high risk of bleeding simultaneously. Often presents with fever, thrombocytopenia, microangiopathic hemolytic anemia, RBCs get shredded passing the clots, neurologic abnormalities, and kidney failure, the classic pentad, though not all are always present. It's a medical emergency.
How is TTP managed?
Plasma exchange, plasmapheresis, is the cornerstone of treatment. It removes the autoantibodies causing the problem and replenishes a missing enzyme, ABMTs13, involved in regulating clotting factor function. Immunosuppression with steroids or rituximab is also used.
And finally, heparin-induced thrombocytopenia, HIT, triggered by heparin.
Yes, this is a huge safety concern. HIT is an immune reaction that occurs after a patient has been exposed to heparin, unfractionated or low molecular weight heparin.
How does it work?
The body forms antibodies that bind to a complex of heparin and a platelet protein, platelet factor 4. This antibody complex then activates platelets, causing widespread platelet aggregation and clot formation, mainly venous clots like DVTPE, but arterial clots can occur too.
So again, the paradox. A drug meant to prevent clots causes massive clotting and low platelets.
Exactly. The platelet count drops because they're all being consumed in these new clots. So if a patient on heparin develops a significantly lower platelet count, typically 50% drop from baseline, or develops a new clot while on heparin, you must suspect HIT.
What's the intervention?
Immediate cessation of all heparin products, including heparin flushes for lines. You cannot give any more heparin. Then, the patient needs to be started on a different type of anticoagulant, a direct thrombin inhibitor, like argatroban or bifolibrudin, because they are now in a highly prothrombotic state. Platelet transfusions are generally contraindicated unless there's life-threatening bleeding, as they can fuel the fire.
Okay, with all these disorders causing anemia or bleeding, transfusion therapy is obviously a frequent intervention, and it carries significant risks. Let's talk safety. Pre-transfusion responsibilities.
Absolutely critical. First, you need a clear provider order specifying the exact blood component, packed RBCs, platelets, plasma, the volume or number of units, and any special conditions, like irradiated leukocyte-reduced CMV negative.
And the type and cross-matched?
It's essential. A blood sample must be drawn and sent to the blood bank for typing, ABOR, and cross-matching against the specific donor unit. Important point. A new type and cross-match sample is typically required every 72 hours. Antibody status can change, especially if the patient has been recently transfused or pregnant.
What's the absolute biggest safety check, the non-negotiable step?
The bedside verification, mandated by the Joint Commission in every regulatory body. Before spiking that bag, two qualified healthcare providers, usually two RNs or RN and physician, depending on policy, must independently verify the patient's identity and the compatibility of the blood unit at the patient's bedside.
What exactly are they checking?
Comparing the information on the blood component tag attached to the unit with the patient's armband and the transfusion order. Patient's full name, medical record number, blood type, patient and donor, unit number, expiration date, everything must match exactly. Any discrepancy, even a tiny one, means S-PP. Do not transfuse. Resolve the issue first. This step prevents most fatal hemolytic reactions.
Okay, verification done, tubing and solution.
Use appropriate blood administration tubing with a filter, standard is 170 to 260 microns, designed to catch clots and debris. Prime the tubing only with 0.9% normal saline, NS.
Why only normal saline?
Other IG solutions can cause problems. Dextrose solutions can cause RBCs to clump or lyse. Solutions containing calcium, like lactated ringers, can cause clotting within the tubing because calcium is needed for the cascade. So NS is the only compatible IV fluid for priming and flushing blood lines. And another action alert. Never add any medications or other IV solutions to the same line while blood is infusing. Use a separate IV site if needed.
Got it. Infusion time. What are the priorities during the transfusion?
Start the infusion slowly, maybe 2 alumolin, or per protocol, for the first 15 minutes, and stay with the patient for that initial 15-30 minutes.
Why is that initial period so critical?
Because most severe life-threatening reactions, like acute hemolytic reactions, typically occur within the first 15 minutes, or the first 50 milliliters of blood infused. If a reaction happens, you need to be right there to stop it immediately.
What about vital signs?
Monitor closely. Baseline vitals right before starting, then again after 15 minutes, then simply hourly during the infusion, and again 1 hour after completion. Follow your institution's policy. Watch for changes in temperature, pulse, respirations, blood pressure, and oxygen saturation.
How long should a unit of packed RBCs typically infuse over?
Usually completed within 4 hours from the time it was removed from the blood bank refrigerator. Any longer increases the risk of bacterial growth in the unit at room temperature. However, for patients at risk for fluid overload, like older adults or those with heart failure.
You need to go slower.
Yes. The infusion rate might need to be much slower, maybe taking the full 4 hours per unit, sometimes even needing diuretics ordered between units to prevent transfusion-associated circulatory overload, TICO.
Are there electrolyte concerns with transfusions?
Yes, particularly hyperkalemia, hypotassium. Red blood cells store potassium intracellularly. As scored blood gets older, some cells break down, releasing potassium into the plasma supernatant. Infusing older units, especially rapidly or multiple units, can significantly raise the patient's potassium level. This is especially risky for patients with kidney failure or cardiac issues.
So fresher blood might be preferred for those patients if possible. What do we tell the patient to watch for?
Education is key for safety. Instruct the patient to immediately report any unusual symptoms or sensations, no matter how minor they seem. Things like chills, fever, itching, hives, shortness of breath, headache, nausea, any pain, especially back, chest, or flank pain, or just feeling weird or having a sense of impending doom.
That impending doom feeling sounds serious.
It often is. It's frequently reported by patients experiencing a severe hemolytic reaction. Trust the patient's subjective report.
Okay, let's run through the main types of acute transfusion reactions. Febrile.
Febrile non-hemolytic reaction, the most common type, caused by the recipient's antibodies reacting against donor white blood cells or cytokines released from them. Symptoms are usually chills, followed by a temperature increase of 1 degree C, 1.8 degrees F or more, from baseline, sometimes headache, flushing, anxiety, usually managed by stopping the transfusion and giving antipyretics. Using leukocyte-reduced blood products helps prevent these.
Hemolytic reaction, the dangerous one.
Acute hemolytic transfusion reaction, AHTR, the most serious, potentially fatal, caused by ABO incompatibility, giving the wrong blood type. The recipient's antibodies attack and rapidly destroy the donor RBCs, hemolysis.
What does that trigger?
Massive systemic inflammation, potential for disseminated intravascular coagulation, DIC, shock, acute kidney injury, circulatory collapse. Symptoms can include that apprehension impending doom, fever, chills, low back pain, chest pain, tachycardia, tachypnea, hypotension, hemoglobinuria, dark red-brown urine as free HGB spills out. It's a true emergency.
Allergic reactions.
Can range from mild urticaria, hives, and itching caused by sensitivity to plasma proteins to severe anaphylaxis with wheezing, bronchospasm, hypotension, shock. Mild reactions might be treated with antihistamines like diphenhydramine and restarting the transfusion slowly if symptoms resolve. Anaphylaxis requires immediate cessation, epinephrine, airway support.
What about lung complications? Turali and taco, they sound similar?
They both affect the lungs but have different causes and presentations. Turali is transfusion-related acute lung injury. It's thought to be caused by antibodies in the donor plasma reacting with the recipient's neutrophils in the lungs, leading to capillary leak and non-cardiogenic pulmonary edema.
So sudden respiratory distress.
Yes. Acute onset dyspnea, hypoxia, bilateral infiltrates on chest X-ray, usually within 6 hours of transfusion, without signs of heart failure or fluid overload. It's life-threatening, requires supportive care, often mechanical ventilation.
And taco?
Transfusion-associated circulatory overload. This is simple fluid volume overload infusing the blood too quickly, especially in susceptible patients. It is cardiogenic pulmonary edema.
How does taco present differently from TRALI?
Taco typically involves signs of fluid overload, hypertension, bounding pulse, distended jugular veins, JVD, shortness of breath, crackles in the lungs. Management involves slowing or stopping the transfusion and giving diuretics.
Okay. Any sign of any reaction, what is the absolute first step?
Stop the transfusion immediately. That is always step one. Clamp the tubing.
Then what? Disconnect the tubing.
Yes. Disconnect the blood tubing from the patient's IV access. Do not just flush the line with saline. You don't want to infuse any more of the blood product that might be left in the tubing.
Okay, stop. Disconnect. What next?
Maintain 4 access. Attach new tubing primed with normal saline and keep the line open, KVO rate, in case you need to give emergency meds. Notify the provider and the blood bank immediately. Stay with the patient, monitor vital signs frequently, initiate the rapid response team if the reaction is severe, provide supportive care like oxygen, administer meds as ordered, antihistamines, antipyretics, epinephrine, diuretics, steroids, depending on the reaction type. Send the remaining blood bag and tubing back to the blood bank for analysis, along with post-reaction blood and urine samples from the patient per protocol. Document everything meticulously.
That stop, disconnect, maintain, access, notify sequence is critical.
Absolutely life-saving.
Last point on transfusions, autologous transfusions, using the patient's own blood.
Yes, it's an option to eliminate risks of incompatibility and disease transmission. Can be done several ways. Preoperative donation, where the patient donates their own blood weeks before elective surgery. Acute normovolemic hemodilution, where blood is removed right before surgery, replaced with crystalloid, and then reinfused after the major bleeding stops. Or intraoperative, postoperative blood salvage, where blood loss during or after surgery is collected, washed, filtered, and reinfused. #outro.
Wow, that was a very comprehensive journey through the hematologic system. We really covered the critical balance, didn't we, between clotting and perfusion?
It really is the central theme. Understanding that balance and what happens when it's disrupted is key to understanding all these disorders.
We hit the crucial assessment points, the history, the physical exam findings like pallor or jaundice, the importance of avoiding splenic palpation, interpreting those labs like the CBC, indices, and clotting tests.
And we dove into specific conditions, the devastating cycle of sickle cell disease, the different types of anemia like iron deficiency and B12 deficiency with its unique neurosigns, the scary reality of aplastic anemia.
Then the excess cells in polycythemia vera and the complexities of leukemia, lymphoma, and myeloma, including the high-stakes treatments like chemo and stem cell transplant, with all their risks like infection during neutropenia and GVHD.
And finally, wrapping up with the absolute necessity of safety protocols in transfusion therapy verification, monitoring, and immediate reaction management.
It's a lot, but it all connects back to those core concepts. So looking ahead, what's the final thought you want to leave our listeners with?
Well, we talked a lot about the genetic basis for many of these conditions, SCD, G6PD, even the chromosomal markers in leukemia and myeloma, and genetic predispositions for clotting, gamma-clotting factor deficiencies. So my question is this. As gene therapy and highly targeted cellular treatments like CAR-T cells continue to advance so rapidly, how do you think this will fundamentally change day-to-day nursing care and patient education priorities over, say, the next decade? Will we be spending less time managing bleeding complications and more time counseling on the ethics and side effects of genetic modification?
That's a fascinating question. It really highlights how rapidly this field is evolving and the challenges and opportunities that lie ahead for nurses. Definitely something to think about. Thank you for joining us on this deep dive.
Always a pleasure. Stay curious, stay safe, and keep learning.